Thank you so much. I mean, what can I say after that? That was very, very nice. Anyway, I'm glad to be here. I'm glad you're all here. It's quite an honor to be speaking to such an astute group, an audience, and these wonderful speakers that we have today. And after listening to Alex and Dr. Kozar and Jennifer, I think my responsibility is awesome. I am supposed to be talking about how to protect yourself and how to protect your loved ones. And that's quite a task, and we're going to, actually, I think I could make it a whole semester class, and, and I have 45 minutes. So I'm going to get started a little bit fast. What am I planning on doing today? I want to talk about, this is what I've been charged with, how to protect your loved ones. So we'll start off with a little bit about your legal rights. Believe it or not, we do have legal rights, but as Alex told us, they're not always as powerful as we'd like to think. I'm going to talk about advance directives in many shapes and forms, such as living wills, power of attorneys, durable power of attorneys for health care, and I'm going to hit heavy the POLST, which is a new form. It's physician's orders for life-sustaining treatment. That can also come like a MOST, which would be medical orders. You can see it in different ways, but I'll talk more about that. I will talk about do not resuscitate orders to a limited degree. And then even more limited is I do want to talk a little bit about the Affordable Health Care Act and how that might affect you and I in the future. How it might, like I say, that's changing, so we'll see what's happening here. Okay, what I do want to start out with saying is that I don't want you to think I want us all to live forever. I don't care whether I'm talking 1992, 1996, or 2013, I know we're all going to die, okay? So I just want to put that on the table that we're all gonna die, okay? And so I'm not trying to deny that. I don't know when, God hasn't told me when, but I do know I'm gonna die. I think what Alex has done has made this slide to me even a little more in your face, is the invisible Holocaust. What kind of a train track are we on? I think it's kind of scary, but maybe it's more realistic than I would like to admit. Okay, so let's start off with your legal rights. You do have legal rights, and being hospitalized can be a very intimidating experience. Patients find themselves thrown into a foreign environment and often feel they have little or no control over themselves and what happens to them. I did an awful lot of research in this when I was working on my graduate work at UCLA, because people lose their whole identity. We not only take your clothing away, we take your friends away, all your valuables away, and we also take your identity away. You're now known as the appendectomy or the cholecystectomy or somebody else. Okay, so dealing with an illness is a stressful time for patients as well as family members, and this stress is magnified by the busy and impersonal environment of the hospital. And in this place, many patients often feel very intimidated, and they don't feel that they can ask the questions that they should be able to ask. And so what I'm going to try and reinforce today is to say that you do have a right to understand what's going on. You have a right to be able to comprehend what's happening, and so you need an explanation for it. And if you can't understand it, you need to recognize that no question is silly. Sometimes we say when we're teaching that no question is silly, and we really mean that. But when we get with a doctor, we sometimes think, oh, they're up here and we're intimidated, and so we hate to ask our questions. But you have a right to get those questions answered. Your information is confidential. This is what they guarantee. Your information is confidential. You and I are all sick of hearing about HIPAA, right? Every time you go to do something, you have to sign a HIPAA. But how confidential is it when it's all on the computers? But anyway, they say it's confidential, so be it. Okay. If you're ESL or you're hard of hearing or can't see, you have a right to an interpreter. You have a right to somebody else there to help explain this to you. I'm going to talk a little bit about the patient's Bill of Rights too. But we've all heard about an informed consent. And I just want to review from a philosophical perspective what exactly we mean when we say we have an informed consent. First and foremost, you have to have somebody that has the decision-making capacity. Okay, you have to be able to make the decision. If you cannot make the decision, you need someone there with you who can help you make that decision. That's not necessarily the doctor, okay? The disclosure, we've talked a little bit about the purpose. You need the purpose, what they're going to do. This could be the procedure, but it could also be medicines, whatever. Risk and benefits and alternatives. Okay, but not only do they need to disclose, I don't know about you, but you sometimes go down and they go so fast with all these big old words that you don't understand at all. And one time I was following the doctor with the charts, and he went like this, and I said, do you think that patient understood anything? He said, I hope not. Okay, so what you're looking at is you have to understand it. You have to understand it. When I was teaching nursing, the way I tried to have the students do is if you have somebody that's signed an informed consent, have them explain back to you what indeed is going to be done. I have to tell you one instance is this student, she went in, Professor Odello, I heard myself being paged, and I thought, oh no, what'd they do now? But what happened is she said, this person doesn't know what's happening. And I says, what do you mean? She says, well, he's going to surgery. And I says, does he have an informed consent? I said, yes. She said, yes. And I said, well, did you ask what was happening? Yeah, well, this patient had cancer of the mouth. And he thought he was going in for part of the tongue to be removed. The cancer had already gone into his jaw, and so he was actually going to lose part of his face. We were going to have to put tubes in. They were going to be doing reconstructive bone surgery afterwards. It was going to go over into his ear. He thought he was losing part of his tongue. Can you imagine if that person woke up in the intensive care unit with those tubes involved, and he thought he was going to relieve part of his tongue? So I called the doctor. I was pretty well known for doing things like this, and I said, we're not sending your patient down for surgery. Of course, they loved me at that time, and why not? There's an I says, there's no consent. He said, I know there's an informed consent on the chart. I says, yeah, there's an informed consent on the chart, but it's not informed. The patient doesn't know. It meets the letter of the law, but it's not an informed consent. And he says, what are you saying I have to do? And I'm saying, if you want your patient down there, you're going to come up and talk to this patient. And he did, not happily, but he did, because that's not fair. You need to be able to report back what it is that's going to happen to you. And it has to be voluntary. And I think, why is his name just, the previous speaker, Alex, I want to get so much in that my brain is going brain. But anyway, Alex has talked about the voluntariness quite a bit, okay? We do have a Bill of Rights, and it is something that is very clear. It's posted in every hospital. You'll see it. And I always read it. And I always thought it was really nice. One of the interesting things it says that I can choose my physicians and that I can get anybody I want to take care of me. And you all know that, yeah, that's a Bill of Rights. And yeah, but it's dependent upon your insurance. It's going to be more dependent upon now with the Affordable Care Act and all of this kind of thing. So there's a lot in the Bill of Rights, but it doesn't necessarily mean that our rights will be protected. But we need to be having the decision-making capacity. But I think the question really is how will my doctor know what treatment I want if I can't communicate? How many of you have a living trust? Just show of hands. Okay, good. How many of you have a living will? An advance directive? How many of you don't know the difference? Okay, oh good, oh most of you do. This is really good. You know, this is unusual because usually you have, everybody's got a trust and very few people have a living will. So we're above the average. This was done a couple of years ago. But this shows you what the percentage of people that have an advance directive is. But what exactly am I talking about when I'm talking about advance directives? And I'm going to have to hit this hard because that's the only way you can protect yourself, and it's scary. Okay, an advance directive says what I want done when I can't communicate. Now, such a document, so many people believe that this is just for seniors. Look at the seniors here. But if you remember the Terry Schiavo case, do you not? She wasn't a senior citizen. You remember the Nancy Cruzan, the Karen Quinlan. Some of you in here are old enough to remember these cases. I'm not the only one, okay? These kids were 18 and 21 years of age, okay? And they were incapacitated. They are not old. This is not just an issue for old people. Any young kid can be in an accident. We know that. Any young kid can have an aneurysm. Look at the people being hit at football, soccer, whatever. You know, things can happen. So young people need advance directives too. But is it important? People say, well, everybody knows what I want anyway. Forget it. Forget it. I want you to think that this is important. Why? If not for you, it's because of your loved one. Your loved one does not need the guilt of wondering, am I doing what they really wanted? How do I know what they really want? We think we know, but unless you've talked to them, you really don't know. You know, I think I know, but I'm not really sure. Okay, so you need to make your loved ones more comfortable so that they understand what your values are and that they understand what it is that you would want. Now, what's going on here? This is something that some of you in the 60s may recognize, okay? I was in the 60s when I started nursing, and I helped set up a couple of these intensive care units. And in Fort Dodge, Iowa, and Omaha, Nebraska, we set those up, and we were so proud of ourselves. We had these intensive care units that were going to protect everybody. We now had respirators on people that weren't in the surgery room. We could put kidney dialysis on. We could put heating blankets on the top and ice blankets on the bottom and keep people's temperatures going. And we could give them blood pressure medicine to keep the blood going. And I swore by the end of the day we could keep a bowl of jelly alive because we had the pacemakers and we had all of these things going. But you know, then people got afraid of all these tubes. This was a really scary thing. So in the 60s, what became known by people like Ann Landers, and everybody knows Ann Landers in the 60s. Now, some of you have read Ann Landers. I'm not the only one. But she was the one that was promoting this living will. Okay, you got to have a living will. What was the living will to do? Well, the living will said, I don't want all this. I don't want this, okay? If I'm incapacitated and I'm going to die anyway, just let me go. And so that's where it all started, is with the living will. Now, we had in California, the living will became legally acceptable in 1976. By 1 year, 43 states had discussed advance directives, and actually 7 had already implemented as illegal. Okay, that was 1976. Yet, let me just remind you, this is the number of people within the last year that have advance directives. So we're kind of slow catching on. Okay, 1976, okay, this is where we're at. So it hasn't worked as well as people wanted, and I will get into that a little bit later. Okay, so what am I suggesting? I'm suggesting, that we need an advance directive. Well, what in blazes is an advance directive? Well, people, they get them all thrown together. You can have them called health care power of attorney, living wills, do not resuscitate orders, donor registry enrollment form that Jennifer hit about, and they can be called anything. And these are all advance directives, but it can become kind of complex. So what I'm going to try to do is to sort some of this out for us. The first advance directive I want to talk about is the most simplistic form. It's a living will. Now, when I was talking to my sister the other day and I was telling her I was giving this talk, and I said, by the way, do you have an advance directive? Oh, yeah, I did that when I did my trust. And that's frequently what a lot of people do. I said, well, what does it say? Oh, well, it just says, if I'm incapacitated, that I don't want to be kept alive by machines. And, of course, then I have a heart attack. And this is my own sister that I've already talked to about this. But she has a living will. Well, what is this living will? It's a very simplistic form, and you have a right to make a check mark. Okay, this is your life on a check mark. And trust me, it's your life on a check mark. It's a choice not to prolong life. I do not want my life prolonged if I have an incurable and irreversible condition that will result in my death. Well, I think life is an irreversible condition that will result in my life, in my death, will it not? And then it goes on within a relatively short period of time. Well, who's defining short period of time? And how many of us have heard that this person is going to die within 6 months or 6 days, and then 10 years later, they're still up walking around, right? So how do they know that it's going to be a short period of time? Well, what if I become unconscious to a reasonable degree of medical certainty I will not regain consciousness? I think Jennifer spoke to that lovely this morning, did she not? And she is not the only person on this planet that's had this happen to him. If you read up, I think Alex probably has things on his website too, but you will see that there's a lot of young people, just like Jennifer, that were diagnosed that they would not become conscious again, who are presently walking around. Okay, and then we also have the likely risk and burdens of treatment would outweigh the expected benefits. But who's defining it? Who's going to weigh the burdens and benefits here? You see, these checkmark things drive me crazy. One other thing I have to tell you on a living will, and I just pulled this down from the website when I put Living Will California, and this is what pops up. Pain relief. Except as I stated in the following space, so it gives you a place to write, I direct that treatment for alleviation of pain or discomfort should be provided at all times, even if it hastens my death. Those words today scare the holy blazes out of me. It really does, because pain control this day and age should not hasten your death. Most physicians will tell you that indeed, because of the way we're able to sync the opiates with the synthetics, that it should not hasten death. Can it hasten death? Okay. In the state of California, we also have a directive to physicians. Oh my goodness, I hit that too much. Okay, a directive to physicians. This directive, I get a little excited, did you notice? And then I start talking fast and I push buttons fast. I do all those kinds of things. But a directive to physicians, what this states is that I can appoint a physician to make my decisions for me. Now, my family, I grew up in Iowa, so we had a physician that took care of mom and dad and all of us kids, right? One physician. Okay, when mom had her 8th child within 10 years and had a ruptured uterus, and the doctor knew she had 7 kids under the age of 10 at home, the doctor was scared she wouldn't make it. I think he was afraid he was going to have to take care of us. But anyway, he stayed right in the room with her. You know, he slept right there to make sure that she was okay. I would give that doctor I would give him that authority. None of us have that kind of doctor this day and age. We don't have one doctor. We have 50 doctors. I mean, you know, you have a specialist for everything. So the advance directive, even a directive to physicians that are legal in California, are not really wonderful. Okay, what is a power of attorney? Everybody knows what a power of attorney is. A power of attorney is a legal document that designates an individual referred to your agent, but this is just, sorry, I got the wrong notes here, just about your financial conditions. A power of attorney, it just worries about your finances. And it becomes illegal if you're incapacitated or if you pass on. They can't worry about your finances. Now, if you have a durable power of attorney, just a plain durable power of attorney, then that can maintain about your finances. That person can be in control of your finances if it's durable, but if it's a regular power of attorney, no. But so what I want to look at is a durable power of attorney for health care, because this is the document that I really want you to become familiar with. Now, within your packet, if you haven't screwed your packet up, on the left-hand side, you will find a paper clip. It's your right, okay, sorry, thank you, I'm dyslexic too, but anyway, that's okay. And it looks something like this, thanks to Elizabeth here, she's put these all together for us. And so this is, what you'll see, the first thing here is my PowerPoint, so that if you wanted to write notes on that, you could do that. If you want to use it as scratch paper, that's okay too. But anyway, the document that I want to refer to right now is the one that looks like this, and it's called an Advanced Healthcare Directive. Okay? Now, this particular directive is put in your packet as an example of what we should have. It's an advanced directive, durable power of attorney for health care. Now, why did I choose this one? Well, it's a Catholic teaching concerning euthanasia. Well, I'll be very honest about it. They gave it to us and it was free, and we were trying to keep our costs down, and so that's why the Catholic one is in here. But you know, there's a list attached right behind it, and there's a whole lot of wonderful other documents on here. And so you don't have to use a Catholic form, but you do need a durable power of attorney for health care. Okay? Now, this particular one says Catholic teaching concerning euthanasia. It's my viewpoint that anybody that respects the human dignity of life has this kind of values that you don't have to be Catholic to have this. So I think it's apropos to probably everybody in this room. But death, we all know we're going to die. Right there it says that. Euthanasia is wrong. I don't want somebody else to kill me. Pain relief, and I think that that's been talked about. I've already talked about that a little bit. You know what? Some people say that you should accept suffering, and I think you should accept suffering if you're good at it, and if indeed you can, if you can offer it up to Jesus and suffer with Christ, I think, more power to you. But if I tried to do that, everybody around me would be suffering, and you'd all know it. And they would say, give that lady some pain medication. Okay. The proportionality of life-sustaining medical treatment, that we don't have to accept everything. And I think both Alex and Dr. Korzar, they both talked about that at some length, and they gave perfect examples, so I don't need to go into that anymore. Nutrition and hydration, they've also covered that. There are certain times it is mandatory, and there are other times. I remember being involved in some cases where it was, the person said, we have to do this. It was causing that dying patient so much pain that no, you don't have to do that. Okay, consultation with medical and spiritual advisors. It's nice if there's people around. And then if you want more information. And by the way, there's more information in this little card. Okay, but what does this have? Why do I want a durable power of attorney for healthcare? Right here on the bottom is who am I going to appoint that's going to make the decisions for me when I can't do it? If I'm incapacitated, okay, or for some reason I can't make this. This is going to be the most important choice that you ever make. And those of you that have gone through this know some people don't do this because they can't figure out who they're going to make as an agent. That's a big thing, because you have to be careful. Now, some people will say, well, maybe you should have your spouse. Well, then other people say, well, hell, my spouse would keep me alive forever. The other person says, hell, my spouse would get rid of me immediately. I don't want that. Can't have that. So then we have to think about, okay, well, what about my kids? Well, let me tell you what I've heard in intensive care. I'd say this particular person, I thought, oh my God, this lady is dying. Why can't we just let her die? Why do we have to do all this? And so I talked to the family. We need her Social Security check. Keep those tubes going. Aghast. I've had that said to me. Okay, then on the other side, I'll have, we need to keep this treatment. The patients, they're saying, we want to stop it. We want to stop everything. Well, let's give it another week, or, I'm really hoping a month, but just give it another week. Maybe we'll have some improvement here. Let's try work a little bit longer. This was on a young kid. No, it wasn't. This was, I was getting two cases mixed up. But anyway, this particular one, then their son said to me, well, I have my kids to educate, and she's eating up my inheritance. You know what? These people are very blunt with me, but I'm very blunt with people, as you can tell. But so it doesn't surprise me, but this is what some people think. So, and how many of us have taught, I think Alex was talking about elder abuse, that's become more common. How many times do we have people that we've seen in the papers that they turn over their house and stuff to their kids, and then the kids kick them out? So be careful. Be careful who you put as an agent. You want somebody that has your desires, your values, and your concern at heart. Okay, do you need an alternative? Yes. You not only need one, but we're moving in a very fast day. People are all over the world, they travel. People should put this in with your taxes so you review it every year, but we don't, but you should. But anyway, so the person may be dead. So you need to have an alternate as well. Okay, just in case they can't get a hold of you. Okay, this is really important. And if you can get a second alternate, that's good. But what's the point here? You've got to discuss what you want with them. If you're ever asked to be an agent, ever, you drill that person and you drill that person about what their values would be like. Give them scenarios, scenario after scenario, if you can. Because you know, we don't have a crystal ball. You know, whatever you've talked about, it ain't going to work that way anyway. And so the better feeling you get, the better idea you have, the better it will be for you. So you need to drill them. Okay, now what else do I have in here that's really important? Okay, it's got to be along with the Catholic teaching. A donation of organs. I think Jennifer hit that. I used to have everybody say you should donate all your organs. I used to have ROPA come into my, I did, don't look at me like that, Jermaine. I used to have ROPA come into my classes and encourage the students to sign up for organ donation. That was a few years ago. Okay, and then we have HIPAA again, and then you have just statement of witnesses. So you don't even have to go to a lawyer for this. Some lawyers will include it in your living trust, most of them do. But if you just go for this, I had somebody went for, I said you need a durable power of attorney for healthcare. And they can charge you from $500 to $2,000 for filling out this kind of a form. And I see somebody shaking their head yes. And you don't need that. As long as it's witnessed appropriately. Okay, and it's all clear who, you can't have somebody that's a relative of your attorney, in fact, to sign it. Okay, you can't have your relative, okay, but you can get other witnesses. Or if you don't have somebody else to witness this, just go get it notarized. That's easy. That might cost you $5, but it's pretty easy. Okay, but a durable power of attorney, where you ask somebody else to be there to make those decisions for you, is the way to go. That's the way to go. And I might say that this is a beautiful document. Is it a doctor's order? No. Does it have to be followed? No. Do you need an agent at the bedside? Yes. You do need an agent at the bedside. Let me tell you, after we got these going, I used to teach these things all the time. I had a fellow nursing instructor, and her mom had just had a heart attack. So she flew back to New York to see her mother. Her mother wasn't that old. It's getting younger every day. But anyway, she wasn't that old. She went into the room, and on top of the bed was this do not resuscitate order. This do not resuscitate order. Marcia said, why is that do not resuscitate order? She just had a heart attack. I mean, it wasn't even a bad one. What is this all about? Well, the nurse says she has an advance directive. Marcia said, did you read it? Well, we don't have time to read them. But because you have an advance directive, people assume you don't want anything done. Okay? That's because, did I tell you when we started with the living wills, that's what they were all about, is don't do treatment. Okay? So you got to make sure somebody is there reading it. You need an agent there to protect you. There's no, I can't emphasize that enough. This day and age, you're almost afraid to have anybody go in the hospital unless, indeed, there's somebody with them. You got to make sure they get their right medicine, and it's just, the nurses are so busy, they try hard, they try to do their best, but sometimes it's a rat race. Okay, do not resuscitate is something I want to hit just a little bit. This is, do not resuscitate is a doctor's order. If you agree to that, and sometimes there's a time and a place for a do not resuscitate order. Bob sent somebody to me last night that I talked to for about an hour, a little bit over, trying to decide on whether the best thing would be do not resuscitate. And in the end, after about 30 minutes, I said, well, can he communicate with you? And he can. I said, duh. If they can communicate, this durable power of attorney is no good. This is only valid if you cannot communicate, okay? If somebody is capable of communication, okay, then that's a good thing. But a do not resuscitate is not something I would ever put in a living will. I would never put it in my advance directive for healthcare because every situation is different, okay? And there's no blanket time for this or that. So this is kind of a scary. There's a time for it, but not in an advance directive. Okay, now it's time to talk a little bit about pulsed. Pulsed. This is this pink form. And I'm afraid I just have gone way off of my thing, but that's okay. Okay, now you'll see this is physician's order for life-sustaining treatment. Hold it up if you've seen it before. How many of you have seen this before? A good number of you have. You know, the worst part is that some facilities are mandating that you have this document before you can go into their facility. Okay? But why did this even come about? Why did it even come about? Well, I showed you our advance directive, this one here, but look at how long it is. Okay, now this is a short one. There are some that are 12 and 15 pages long. They're very confusing. If you're a nurse or a physician in a hurry and there's no standardization of these forms, what are they going to do? They're going to ignore them. They're going to ignore them. And yet they recognize that they really want to have people's ideas. So what they decided to do was to make it a simple form. This is a simple form that everybody would recognize. If this is on the chart, then this is what it is, okay? So we know. I'm afraid, though, that what they see when they see this is that you don't want anything. But anyway, hopefully they'll read this. But let's just look here. On A, it says cardiopulmonary resuscitation. If a person has no pulse and is not breathing. Well, what if I have a pulse and I'm not breathing? Now, are you not going to do anything for me? Because could I not have choked on something and a little Heimlich might make me okay? If I say nothing is to be done? Excuse me? What about that? Did you hear about that case in Garden Grove where that lady collapsed on the floor and the aide, when she was asked why she didn't start CPR, is because they had been ordered by their employer not to give resuscitation? Is that crazy? Okay, but now that person, the employees had been, anyway, that's now illegal, but we'll see. Because it's illegal, it doesn't mean it's not done. Okay, so it says, and then your other one is do not attempt resuscitation. And that means allow natural death. Okay, you know, allowing natural death sounds like the way to go, right? But do not resuscitate. Okay, you know, we're fooling with natural once we start giving antibiotics, once we started giving blood, once we start doing anything. It's not natural, come on. So we've been doing chest compression since the 60s, okay? So it's a treatment. In certain instances, it's a treatment. My brother-in-law, just a year and a half ago, he's younger than I am, and he's a doctor. He was in taking care of a patient, and boom, he's down, he's out. He is out, okay? He was in a medical clinic, he's a doctor. Well, they start pounding on his chest. Okay, if he had one of these things signed, he wouldn't be taking care of patients today. Now, he did have to have heart surgery, he had to have a stent put in, but what happens is they resuscitate it. And these things are to go with you. They're not to be just in one. You just don't do when you go into one hospital one time. You're supposed to take this with you forever. And if, oh, by the way, if you're home, you're supposed to put it on your refrigerator. So if you have an emergency and EMT comes, then they know that they don't want to resuscitate you either. Okay, another thing is comfort measures only. If you say you want comfort measures only, I mean, it sounds good. Relieve pain and suffering through the use of medication by any right positioning, wound care, and other measures. Okay, let me tell you about another story. A friend of mine, he had cirrhosis, and now he was getting towards end stage. And so they had called in the hospice, and that was fine. And he had gotten comfort measures only. Well, with cirrhosis, you know, sometimes you get ascites. You get all this fluid. Okay, and what do? You have to drain it, or else you become very uncomfortable. They wouldn't drain the ascites because he had said comfort care only. Dig that, dig that. How stupid is that? I love check boxes. Did you get that feeling? Yes, okay. Just don't do it. Okay, artificially administered nutrition. I love that. Alex told us this morning, too, even spoon feeding is now a medical procedure. Excuse me? What about these people that, anyway. So what happens is that This is a doctor's order now. This is not an advance directive. Once you sign, well, you're supposed to sign it because it's supposed to be voluntary, but 2 states you already don't have to sign it. But anyway, this becomes a doctor's order immediately. So you have to be very, very careful with this. Now, if I was reading on one, and I can't remember which Catholic organization it was, it says if you must sign this, just say you want everything. And then, but above all, try not to. I went to 2 hospitals that said that you had to sign this, and I really pushed them. I said, oh, then I'm going to have to take my loved one someplace else. They said, well, if that's the case, you don't have to sign it. Okay. So I'm sorry, I really have to move on just a little bit because I really want to go into a little bit of Obamacare or the pulse. Let me just review this real fast. The good thing is it's a simple checklist. It's very easy. That's a bad thing. You got that picture. It's voluntary. Okay, so they say because the patient consent is not always required. And, you know, the other thing is, I have to say, there's trained facilitators that know how to come and ask you these questions, and they come with a bent towards getting you not to have anything done. They'll say, oh, you really don't want CPR because, you know, you're going to have your ribs are going to be fractured, and you probably won't live anyway. And you know, it's the way they ask the questions. And you all know about statistics. It's all about the way they ask the questions. So these trained facilitators are the person that really helps you fill this out. And they do help you. But what happens is that it's not always what you really want. It's signed by medical personnel, and that sounds good. But the doctor signing it may not even know who you are. They don't have to be your primary care. And if I go from hospital to hospital, that doctor may not even have admitting orders in another hospital. And yet this is a doctor's order and it's valid. So it's kind of a scary document to me. A doctor's orders must be followed, okay, and it overrides a DPAC. Okay, so that's just it in a nutshell. And there's a brochure in here that was written by one of our wonderful nurses, Jermaine, and this is excellent, so read that. Okay, now I know there's so many questions, guys. Can I talk about Obamacare for just a little bit? Okay, durable power of attorney, that's what you need. Durable power of attorney for health care. The best way to stay on course is to have an advance directive, documents with discussion with family and healthcare providers, and have that patient with you, an advocate at all times. Okay, Affordable Health Care Act. I'm going to have to go through this fast. More young people are insured. More people are insured. That was the plan, was it not? The Affordable Care Act, you guys, we are one of only 2 nations that do not have some kind of universal health care. Okay, us and South Africa. Okay, so we need something. But is the Affordable Health Care Act the way to go? I'm not really sure. But anyway, it's more people insured. Young people are covered until 26 on the parents' policy. Now, this is, I'm really pleased with that. Except on the other hand, there's maybe now 16 million people. Now this is what I heard Friday. 16 million people will now lose their current insurance because it doesn't cover everything Obama wants to have covered. So while we'll have more people covered, and the reason we get more people covered is because they've upped the Medicaid and the Medicare exemption, and there are subsidies. So yeah. Okay, pre-existing conditions is no longer a limiting factor, and that's a good thing. Those are all good things. There's no doubt about it. But here, this is California. 4.8 million lost their insurance. This is the really biggie, the HHS mandate. Everybody knows about that? Okay, that's hitting right now. The Supreme Court's looking at whether they're going to look at some of the lawsuits. 5 minutes, okay. But this is really scary. If they tell us what we have to do, what we have to include in our insurance, when are they going to be telling us what exactly we can do? And they already are. The 50-time full-time employees requirement, what people are doing is if they're around 50, they're just cutting some of the full-time people to part-time, and then people that were giving part-time employees insurance are now taking them away and giving them a little subsidy. So I'm not sure this is really helping a whole lot. It increases the part-time jobs. Consultations on end of life, the death panels, as Sarah Palin says, it is written right in the law that there will be a consultation on end of life issues and that they will pay for end of life issues, a consult, but it'll only be done once. And, you know, my life goes on, and what I am today, I may not be tomorrow. And I think it's good that the doctors, and you talk about end of life, but I'm afraid that some people would respect their doctors so much that this could also be pressure into signing and agreeing to something that you don't want to. So this could be both good and bad. But here's the other thing that really bothers me. What treatments will be covered is not determined by your doctor. There is going to be a group, a committee, that will decide what will and will not be covered. And I read in one of my medical journals recently, just last week, that many doctors now are planning to retire early because they're afraid that they're going to lose autonomy in medicine. And the issue is that we're supposed to be including more people, but yet it's supposed to cost us less. How's that going to happen? I mean, is that not multiple rationing is the way we're going to have to do? They say we're going to get more young, healthy people in, and that's going to offset it. But if you're a young, healthy person and you think nothing's going to happen to you anyway, are you going to pay $1,000 a month, or are you going to pay the fine, which is $95 a year? I mean, come on, get real here, right? Even if I'm making $50,000 a year and I think I'm healthy, I have to pay 1% of that, so I would have to pay $500, but that was still a lot less than what you would pay for insurance. So there is going to have to be a crunch someplace. So, but I could say a lot more, but I've already gotten the 5-minute sign. Okay, so you already know what I talked about, so I won't go over this. The end-of-life planning, it's never too early to begin. If you have, many of you have an advance directive, look at it again with what you're hearing today. Okay, ensure your wishes will be heard. Talk about it with your family. And I saw a couple of questions. I think I might have 1 minute. Okay, do I have a question? I saw all these hands. I don't have a question. Okay, right here. In a checklist form, in an advance directive. Don't write, do not resuscitate in either a living will, if you're going to use one of those, but please don't, or even in an advance directive. Yeah, don't use DNR. Because you know why? We don't know what the circumstances will be. There are times you want an order, there are times you don't want an order, okay? So you have to take the whole situation into consideration. And so there are times when it's good on a doctor's chart, but not on an advance directive. Yes, sir. Yes, yes.
I've been helping somebody out on this stuff, and I can tell you that things change rapidly.
Very rapidly.
You may have an order that says one thing, and you want it the other thing, and vice versa. So I think you really have to have somebody proactive in terms of all the healthcare, major healthcare, or outside the hospital. You're kind of subject to not only clerical, but also you're not there to correct mistakes by even doctors in emergency rooms who make assumptions.
He's
Let's say that the patient said don't resuscitate when the patient's in a situation of depression, when that changes as soon as he's out of the emergency.
okay. What he's saying is that, you know, you really need an agent there because things change, not just month or day, but it can change hour, minute by minute. And so you really need somebody there with you to that will fight for you. That will fight for you. Let me tell you a story about my mother-in-law. My husband is over here. God love him. He's always my moral support. But anyway, he's put up with me for 42 years, so you have to give him a hand. But anyway, what happens is he had a lovely mother. And she was in a assisted care facility close to us, and she was eventually diagnosed with pancreatic cancer. Well, you all know that that's a god-awful disease. Okay, and it goes really fast, so they said they were going to bring hospice in, so that was all okay. And Mom was in some pain, but nothing that couldn't be controlled by ibuprofen. So after we brought hospice in, about 2 days later, I go in, and Mom is like a zombie. Jenny, what's up? Now, prior to this, I'm able to talk to her just like I'm talking now. And you know me, I talk. And so, and it was like, she was out of it. And I said, what the blazes? I went out to the nurses. I says, what have you done to my mother? I said, what's going on? Oh, well, she was in pain. I says, I'm sorry. I know what her pain level was. I've been taking care of her. We've been in here every day. What do you mean she was in pain? Well, she had a lot of pain. I says, well, give her some ibuprofen. What have you given her? It took her 2 days to come out of that, because they had so doped her up. But I was worried when I'm hearing some of the things that I'm reading about. I wonder what would have happened to her if I hadn't been there yelling and screaming. Because then she was able to, we took her out shopping after that. She was able to eat. She was able to converse. I don't remember how long she lived, probably 3 or 4 months maybe. I don't know, it wasn't real long. But, and she could sit, my daughter would go over and have popcorn with her and watch a movie. But if you're zombied out, so you really, I'm reinforcing what you say. You need an advocate there to take care of you. There's no doubt about it. It's the most important thing possible.
The emergency room doctor told me that he was not on full code when he was. They actually
Yeah.
lied or whatever.
Just not quite told you the whole truth. Yes. Why?
Because she had a do not resuscitate order.
Okay. Did you hear that this was the case that they wouldn't give her aspirin or ibuprofen because she had a do not resuscitate order? That's a bit extreme. Luckily, I haven't heard about that so much. But I think I've got the stop. Bob says, we're all worried about you getting lunch, and they're cutting us off at 12:30. So I think Bob says, Betty, it's time to be quiet.